we still don't have a webcam for Weiler?
No, you see what they did at Weiler was, you understand what happened there? Is that
No,
Sham
I
said
don't
he fixed the
understand.
computers,
Yeah.
but what he did was he just disconnected one computer, swapped out, I told him not to do this, swapped out one computer for another computer.
Okay.
That is hardly a fix for anything, instead of having IT come and fix the problem.
Okay. Weiler, are you with us?
Yeah,
Okay, we're just a little upset we can't see you.
sorry. We're smiling.
You're smiling? All right. You have any way to prove that you were at Weiler? What did you eat for lunch today?
German food.
That sounds right. That's a Weiler.
And how was the German food?
It was okay. How was your lunch, Abby?
Okay, all right. Sounds like you're at Weiler.
Abby had schnitzel.
Confirmed, Weiler. Okay, cool. So we're going to do, this is one of our basic subjects, pressors and inotropes. It's a little out of order this year because I decided to do some requests to do ventilators earlier. We're going to do the more advanced ventilator topics, I guess, next. And anyhow, so what I have for you is a teaching file. Anyone doesn't have access to the CCM resources folder, text me or leave me a message or something, email me, and then I'll give you, I'll share it with you because we have a lot of stuff on it. So there's a basic teaching file on pressors and inotropes, basic mechanisms of action, what they're used for, what the dosages are, and there's case scenarios, which is mainly what we're going to be doing today, and some questions. And then I have 8 articles, I believe. This is not expanded recently. There's nothing new under the sun that I know of unless until this latest study Michelle's on comes out, I guess. Until we start using angiotensin. Anyhow, so an old subject. What are the articles I've put in here? There's one review article from CHEST that's worthwhile, pretty straightforward. I think it's good. There is one I always try to throw in one classic article. Anything with the name Gattinoni on it's going to be a classic article from '95, and this was sort of the beginning of the end of PA catheter-directed therapy in patients in shock states. Basically, in the 80s, 90s, a lot of critical care practices were using, in patients in shock, PA catheters, not only to direct resuscitation of patients, but also to guide oxygen delivery. And there was this overall thought that somehow you could push patients not only to normal indices of oxygen delivery, but to supernormal indices, and that would somehow help them get through their critical illness. And so even when I was in fellowship, we were still doing this. It hadn't been completely killed. We were doing this to some degree. But this was sort of the beginning of the end of it was a trial where they actually randomized patients to all of whom had PA catheters in, because back in that time, everybody who was in shock essentially had a PA catheter in, and randomized them to either normal normal indices of oxygen delivery or supernormal indices of oxygen delivery. Either the supernormal groups were either attempting to achieve increased cardiac indices or increased central or mixed venous oxygen saturations. So a huge study, 10,000 patients were screened and 760 enrolled, and patients were mixed between septic or distributive and cardiogenic shock states. And I'm not going to go over it too much, but essentially they showed no mortality improvement in the patients who were randomized to the supranormal physiology states, essentially. And people would always say, well, the reason you're not showing benefit is because you're not achieving your goals. Actually, they also did a subset analysis of patients who achieved their supraphysiologic goals, and there was also no benefit in achieving supraphysiologic goals. So this was where, this sort of killed PA catheter-directed therapy for shock states. The time that this sort of came back to some degree was the early goal-directed therapy days. It was sort of a less aggressive way of doing this. It was more directed at patients in the first 6 hours. This was more directed in patients in critically ill states once they're in the ICU. The early goal-directed therapy early trials were in patients in the emergency room, and even though the initial results showed positive benefits to aggressive early resuscitation, including fluid resuscitation, using inotropes if mandated by the algorithm, and using blood transfusions if mandated by the algorithm, subsequent studies did not really back that up, and the overall thought from the early goal-directed therapy, all of the studies, is that I think most people agree now that early resuscitation is important. Early recognition of shock, particularly septic shock states, is important. Early resuscitation is important, but the use of things like inotropes and red cell transfusions to achieve specific targets is probably not routinely beneficial. May be beneficial in patients who are very anemic or have very profoundly depressed cardiac function. Anyhow, so I didn't include the EGDT articles here, also because they more are really directed at the first 6 hours of resuscitation, which is only a little bit of what we do. Other articles of interest here, this was a article that should have been done a long time ago. It took till 2014 to come out in the New England Journal. It's always been a question, and in the past there was only one very small study showing that there was no difference in outcome if you attempted to achieve a mean arterial pressure of 65 versus higher in septic shock states. Our standard has always been a mean arterial pressure of 65 in septic shock, and that sort of came from more from animal models than anything. There was one small study showing no improvement if you target a mean arterial pressure of 65 versus 75. And so this actually randomized patients in septic shock to a mean arterial pressure of 80 to 85 versus the more standard 65 to 70. Did not show a benefit to the higher mean arterial pressure group. The only real difference was that the higher mean arterial pressure group had a higher incidence of atrial fibrillation. The only potential benefit in subset analyses was in chronically hypertensive patients. If you targeted a higher mean arterial pressure, they had a lower incidence of need for dialysis, but no difference in mortality. So basically it backed up our usual mean arterial pressure goal of 65, but also gave some degree of credibility to the idea of, oh, this patient's chronically hypertensive, maybe you should be targeting a slightly higher mean arterial pressure. Any questions on that so far? All right. I don't know why this study wasn't done earlier. Other articles here, the SOAP2 trial, there's been a long debate between over the use of the best, the ideal vasopressor in shock states. In Europe, dopamine was very much the preferred vasopressor. In the United States, norepinephrine for a long time has been the preferred vasopressor. And so this trial randomized patients in shock state to either dopamine or norepinephrine and allowed norepinephrine and epinephrine and vasopressin to be added as well if needed. But the question was whether or not you started with dopamine versus norepinephrine in these patients. Mixed group of patients between distributive and cardiogenic and mixed shock states. Really, again, a large trial, 1,600 patients. No difference really in outcomes between norepinephrine and dopamine. They did show an decreased incidence of AFib in patients who received norepinephrine than dopamine, but that was about the only difference. And then kind of strangely and somewhat counterintuitively on subset analysis, they showed that patients who had cardiogenic shock states did worse on dopamine than norepinephrine, which was a little bit counterintuitive in the past. Even in the U.S., if somebody was more in a mixed shock state or more in a cardiogenic shock state, we used to go to dopamine ahead of norepinephrine because of its, at low doses, more potent inotropic and chronotropic effects. Anyhow, didn't seem to pan out as a benefit. So this sort of favored norepinephrine as your sort of initial pressor of choice if you don't know much else about the patient. You'll still see dopamine on the crash carts, right? That's what's available to us on the crash carts. That has more to do with storage of the drug than anything. Any questions about dopamine versus norepinephrine? One might use one versus the other.
But now you usually add on a second agent before you max out to take that synergistic effect into action, right?
Sure. I mean, we can talk about that. We'll talk a little bit about vasopressin. Dopamine is, you know, it's an agent that has varying effects at varying dosages. So at low dosages, it has more dopaminergic and beta agonist effect. At higher doses, it becomes more of an alpha agonist. It's also not as potent as norepinephrine, you know, so there's no, you know, the upper limits of dopamine dosages aren't as potent as the upper limits of norepinephrine dosages. So anyhow, we don't use it much in the unit anymore. You see it on the floor these day and age. The only other thing about dopamine, there was always this idea, and I did include this one of many, many trials looking at renal dose dopamine. I probably will not include this next year because I've stopped hearing surgeons request renal dose dopamine finally. So there was always this idea because of the fact that at low doses dopamine increases renal blood flow, that dopamine might be sort of nephroprotective in shock states. And essentially multiple trials showed that it was not nephroprotective. It is at low doses it's a natriuretic agent and a diuretic agent, but it does not seem to reduce your risk for need for hemodialysis, for instance. So sort of idea of these low or renal dose dopamine, it's pretty much gone, I think, in this day and age. I don't know. Yes?
Well, if patient Keene has like a bradycardia and also has hypertension in shock state, could we use like a dopamine instead of
You could, and in the ACLS algorithms, suggested, and it's another reason that we have it in the on the code cards and the like. You know, honestly, at the lower moderate doses, norepinephrine has quite a bit of beta agonist effect. So, is there really a benefit to dopamine over norepinephrine in relatively bradycardic patients? I'm not sure, to be honest. But yes, that's a classic indication for, yeah.
Also, if we don't have like a central line,
yeah.
could we use like dopamine as a...
You can use any pressor. You know, none of them are good, particularly if you if they infiltrate. And dopamine, some people feel is somewhat safer. You can use any pressor through a peripheral line, and we will do that here as long as it's a good peripheral line and as long as it's temporary. But no pressure should really be given long-term through a peripheral line. Yeah, but that's been the other reason that we've used it on the floor more frequently, is that it may be a little bit less, cause a little bit less skin and soft tissue toxicity if it infiltrates. What else is here? Not answer. The VAST trial, which is looking at vasopressin in septic shock, really shouldn't be called vasopressin versus norepinephrine infusion. It's norepinephrine infusion versus norepinephrine and vasopressin infusion in patients with septic shock states, but it's simpler to present it as this. Basically, vasopressin became of interest as a pressor in the late 90s, I believe, when Tom Landry at Columbia was using it, was noticing that patients who were getting it for with variceal bleeding were receiving it to reduce splanchnic pressures. When they would come off, if they were septic in addition, as they came off their vasopressin infusions, they tended to get hypotensive, so we started to think about it as a pressor. Did some studies in patients in septic shock showing that early on in septic shock, your endogenous vasopressin levels spike very high, but then very rapidly come down to low normal levels. So there's this idea of relative vasopressin insufficiency in septic shock came up. He did like a very study that was not an RCT using vasopressin in septic shock that seemed to indicate some mortality benefit, and this was a large follow-up trial looking at patients who were in septic shock, who are already on a moderate dose of norepinephrine, and randomizing them to either the norepinephrine plus vasopressin at a fixed dose, or just titrating up the norepinephrine as needed. And basically, another pretty well done study, close to 400 patients in each group, and basically they didn't show any mortality difference at their defined 28-day endpoint for the patients who got vasopressin and norepinephrine as opposed to norepinephrine alone. There was a reduction in norepinephrine use or need in the vasopressin group, which we've all seen. There was a subset analysis which was also kind of hard to figure out what to do about. They had a predefined subset of patients with more severe and less severe septic shock. And I think what they were hoping for was that the patients with more, maybe if they didn't find a overall benefit in all patients, that they would find that the patients with more severe septic shock would benefit from vasopressin, because that's the people that we tend to use it in anyway. Unfortunately, they didn't show that. What they showed was a mortality reduction only in the patients with less severe septic shock. So that's kind of a hard one to bend your mind around also. Like, maybe it benefits the less sick patients, but those are usually the patients who are just needing low doses of norepinephrine anyway, so we wouldn't usually add vasopressin to them. So this didn't kill the uses of vasopressin. It didn't show harm. It showed that your norepinephrine, as we already knew, your norepinephrine requirements would go down, and we still do use it for that purpose because we like norepinephrine requirements to go down. Whether that's good or bad, I don't know. We use it also because of the positive chronotropic effects of norepinephrine. If somebody's very tachycardic, then maybe it's beneficial to add it for that reason. Other things about vasopressin that are kind of interesting is it tends, although it causes overall vasoconstriction, it tends to vasoconstrict the pulmonary arterial bed less than other vasopressors. So patients with pulmonary hypertension, for instance, who are receiving milrinone, somebody with RV failure receiving milrinone, the classic drug to sort of offset the systemic vasodilatory effects of milrinone is vasopressin. So maybe a potential benefit there. Still a useful drug. Nobody really knows about its use alone. We were always sort of, when it came out, warned against using it alone. There have been specific complications associated with it, digital ischemia, tongue ischemia. But honestly, that can occur with all the pressors. Once in a while, you'll hear the vascular surgeons will find out one of their patients is on vasopressin, they'll get very upset. Those are the main studies. The only other study here that was like kind of a mind blower that really nobody knew what to do about, but a big deal was made about that came out in JAMA about 3 years ago. Was a study looking at patients in septic shock and randomizing them to the opposite of what we would usually use for septic shock, to a beta blocker in septic shock, and essentially took patients who were relatively tachycardic in septic shock and randomized them to either just ongoing standard of care management or esmolol, which is a very short-acting and titratable beta blocker, to bring their heart rates down to between 80 and 95. And they had like amazing results across the board. They showed a mortality reduction of, from 50% in the beta blocker group to versus 80% in the control group. They also showed other interesting things like increases in cardiac index in patients who received esmolol, decreases in pulmonary capillary wedge pressure in patients who received esmolol, reduced fluid requirements, all sorts of good stuff with the esmolol. Not a huge study, about 150 patients total. They were very sick patients. They were on relatively high doses of norepinephrine to begin with. They had SAPS-2 scores, which we don't use as much. Interestingly, if you look up SAPS-2 scores and what the predicted mortality is at each of these SAPS-2 scores. So for a SAPS-2 score of 52, the predicted mortality is 50%. The esmolol group had a mortality of 50%. So maybe it wasn't the esmolol, maybe that was just what the mortality they should have had. And for a SAPS-2 score of 57, it's a part of the sort of steep part of the SAPS-2 curve, but the predicted mortality is about 60% as opposed to the control group which had an actual mortality of about 80%. So the question became, was it not that the esmolol was beneficial? Was it just that the control group did really, really poorly, which it seems like they did an 80% mortality, much higher than would be predicted by their SAPS-2 score. So I haven't seen this come in, be used in clinical practice outside of some very specific indications. We have one patient up in the surgical ICU now who's on esmolol, but very rarely used. But there's interest in it. Is this sort of hypersympathetic state of septic shock harmful? Is there something that's too hypersympathetic about it by throwing all this alpha and beta agonism at patients? Are we doing them some additional harm, and is there some way that we can modulate that or mediate that by putting on a blocking agent? It's possible. I just don't think we're smart enough to know who to do it to, how to do it to them. It's kind of like, I think of it like all the anti-inflammatory agents in septic shock. There are pro-inflammatory cytokines that go out of control. We never know on a specific patient which cytokine is too high, which cytokine is too low, or how to control it. So we're just not at that stage of knowledge. So anyhow, interesting sort of thought-provoking study. Any questions or comments on that? We had our head of chairman of ID announced after this came out, right, that we had found a cure for sepsis and we should stop all norepinephrine infusions and start all septic patients on beta blockers. So interesting. Anyhow, what's that? Yeah, you've been doing that?
I don't give anyone beta blocker.
Nobody's. Why is it on the fanny? Why is it in his fanny pack?
Oh, we gave it to the person that was having a STEMI on Friday.
I thought it was actually for the fellow whose hand was shaking while trying to do an intubation.
I gave it to the patient who was having a STEMI,
Okay.
then was shortly reminded afterwards by the primary service when I said the patient should have oxygen, that oxygen could harm the patient.
You never heard of oxygen toxicity?
No, I know, but I said like the patient should have oxygen in case they're going on cath lab, they're going to elder, who knows what's going to happen. Don't give the patient oxygen, too many radicals, too many free radicals. And I said like, okay. So I just stopped there. But
all right.
I don't give anybody esmolol in the setting of septic shock.
Somebody? Yeah, we never did. Anyhow, the few times I've tried sort of empirically, because I thought it was a good idea, it was a bad idea. It didn't work.
It almost doesn't, it just, like, I know that it just doesn't make sense conceptually.
This is, how do I go back? How do I close this without hitting escape?
I think you're one screen back.
What's that?
One tab back to the left.
Thank you. Which one did I choose? Better. Okay. All right, so we're going to do some questions. We're going to go around, including Weiler, which we can't see. But people can volunteer. We're not going to, like, pick anyone out except for Dr. Shiloh. So first question regarding, so the first 5 questions are pretty simple, and they just refer to the evidence that we kind of went over. Regarding critically ill patients with renal dysfunction, the best available evidence suggests that renal dose dopamine, which of these answers do you guys think is correct? All right, so we said C, no effect on either renal function or mortality. Okay. Question 2, regarding the use of norepinephrine versus dopamine for shock states, the best available evidence suggests that which of these? So you're right. So neither confers a survival benefit. Norepinephrine tends to cause less arrhythmias. The arrhythmia it tends to cause less of is AFib. which we can deal with, but anyhow, that's the case. And C is like the trick answer. Dopamine benefits the subset with cardiogenic shock, and norepinephrine benefits the subset with distributive shock. For whatever reason, in SOAP2 trials, they showed the opposite of that. So, okay, question 3. The addition of fixed-dose vasopressin to norepinephrine in patients with septic shock has been shown to which of the above?
Weiler says B.
Weiler says, thank you, Weiler. Okay, right. So the thought was maybe it would be C. The VAST-2 trial showed that it was B. Didn't show it, didn't lower overall mortality, but somehow in this weird way maybe did for the less sick patients. I don't know what to do about that. Because we only give it to the more sick patients.
I know.
I'm sorry. Science doesn't always provide convenient answers. The use of goal-oriented therapy, including inotropic agents to target supernormal levels of cardiac index and oxygen delivery in critically ill patients, has been shown to which of the above? Have no effect on mortality, increase mortality, reduce mortality only in that subset of patients who achieve the supernormal target. So C would be the answer, D would be the trick answer, C would be the actual answer. You could always, I'm sorry. A would be the answer.
Yeah, these guys
A would
did
be the
it.
answer. Thank you, guys. You could always argue, hey, it had no effect on mortality and it was a lot of fun. So
Hey, how's it going?
start doing it again.
Oh, visitor?
We should prove that we kill people with it. Other studies prove that we kill people with it. Anyhow, I didn't go over this article with you guys. So there's one article there. It's not a well-known article particularly, but it's the best article that I could find that compares the hemodynamic effects of dobutamine versus milrinone overall, and this is done in a very controlled fashion. It's done in patients with low cardiac indices after cardiac surgery. So we usually use dobutamine and milrinone in patients with low cardiac indices. Most frequent place we see that is after cardiac surgery. So these are all patients who had cardiac indices under 2, and I think the mean was 1.6 or something. And they randomized them to milrinone 0.5 mics per kilo per minute, which is sort of a moderate dose, versus dobutamine at 10 to 20 mics per kilo per minute, which is a pretty high dose, actually. I think you're talking about 20 mics per kilo per minute of dobutamine. And they looked sort of over time at the hemodynamic effects of the two drugs. I feel like and it's a little hard to make all of this out, but I think what's important is that if you look at these numbers, you see some trends. The cardiac index overall went up slightly more in the dobutamine group. One thing about that I would say is that the dobutamine dosages used were higher to me than the milrinone doses relatively. So cardiac index went up slightly more in the milrinone group. The wedge pressure tended to go down more in the milrinone group. The heart rate went up more in the dobutamine group, which I think we all see. So heart rate, mean increase in heart rate was 35%. As opposed to 10 to 15% in the milrinone group. The mean pulmonary artery pressures, if you look at them, they were slightly up in the dobutamine group and slightly down in the milrinone group. Sometimes we think of milrinone as a decent pulmonary vasodilator, and we use it more in patients with cardiogenic shock who have RV failure and pulmonary hypertension. So that sort of backed that up to some degree. The systemic vascular resistance went down further in the milrinone group. It's a frequent effect that we see of milrinone. Patients get more hypotensive in general on milrinone. In the dobutamine group, only slightly from that beta-2 agonism. And then if you look at the stroke volume index, though, the effect is almost exactly the same. And I think, in fact, in some cases, it's a little bit higher in the milrinone group. So, what's a stroke volume index? Anyone know what stroke volume index is?
Stroke volume adjusted for the patient.
BMI.
Yeah, yeah. So right, it's stroke volume. It's not cardiac output, and it's adjusted for their height and weight. Just height actually, but right, just height.
Body
surface area. Thank you. Sorry. Body surface area. But I think we just do that based on height. Anyhow.
Yeah. Yeah.
So this is the output of each beat relative to their size. So in other words, with dobutamine, your cardiac output is going to go up a bit more, but that's mainly because of the chronotropic effects. And the inotropic effects are about equivalent of the two drugs. And so that's all. So, and then you'll see that, when you use dobutamine, it's quite predictable. If you're going to have an effect, the heart rate will have gone up predictably. If it's not having an effect, the heart rate won't have gone up. Right. Index. Okay. That's this last weird question. Question 5. Regarding the use of inotropic agents in post-cardiopulmonary bypass patients, which of the following is true? Milrinone is more arrhythmogenic than dobutamine. I didn't go over that with you, but it's actually the opposite. Dobutamine, there's a higher incidence of AFib with dobutamine usage than with milrinone, so it's something to know. Then again, dobutamine is much shorter acting, so if somebody goes into AFib on dobutamine, it's really easier to titrate it off or take it off if you need to. Milrinone sticks around longer. The answer B, milrinone has been shown to cause less increase in cardiac index, but similar increase in stroke volume index when compared to dobutamine. I think that's what I was looking for as the answer. Does that seem right to you guys?
Did you say it was more of an increase in cardiac index?
Less in cardiac index, but similar stroke volume index, right? Because cardiac index is not adjusted for heart rate. Cardiac index is stroke volume times heart rate, right? Adjusted for your body surface area. Right, so that's all I would say. They're both causing the same amount of inotropy, with dobutamine causing more chronotropy. Okay, we'll do some cases. They're more fun, I think. Case 1, 65-year-old female, chronic renal insufficiency, AFib, pneumonia, septic shock, respiratory failure. Your average consult. 7 liters of normal saline and antibiotics in the ED, admitted to the MICU on norepinephrine 0.5 mics per kilo per minute. Her temperature is 102, heart rate is 82 and irregular, her blood pressure is 105 over 52. She's breathing at 24. She's statting 100% on 50%. Her CVP is 14. She's intubated, sedated. She has cool extremities. She's not urinating. She has a white count of 18,000, a creatinine of 3.9, up from a baseline of 1.8. A blood gas that's not too terrible except for a lactic acid of 4.2. and a central venous oxygen saturation of 54%. Her TTE shows severely reduced LV function, normal RV function, an IVC of 1.5 centimeters with minimal variability. Her pulse pressure variability is 22%. I guess she has an A-line in at this point. What would you do next? So, wow, I haven't looked at this for a while, so I don't know the answer. I got to think about it. But think about it and let me know any thoughts on this case.
Pulse pressure variation means you're still volume depletion.
Okay. So what are the limits to pulse pressure, measuring of pulse pressure variability?
So you can't.
Yeah.
Right. So AFib, your pulse pressure variability is always going to be huge, right? So that's one of the exclusions from paying attention to a pulse pressure variability. So we've lost that in terms of our ability to use that as an indicator of likely responsiveness to further fluid resuscitation. What about her echo?
Sounds like septic cardiomyopathy with poor LV function. RV looks like it's working well, and according to these parameters, all hints are that she's at least euvolemic.
Okay.
She's still shocky with a low central venous. So I think she needs some more forward flow. Dobutamine would probably be a good bet for her.
Okay. Yeah, so, right, so the echo, I guess you can't say is it a septic cardiomyopathy or is this an underlying cardiomyopathy, but because you don't know her or what her prior cardiac function is, or I didn't tell you, but it could be septic cardiomyopathy. Right, and so, you know, she's not urinating, she has a lactate. I don't tell you if that lactate's coming up or down, so that would have some effect in terms of what you do. Her central venous sat at 54%, that's low, moderately low, right? Generally, central venous sat is from a central line, right? So essentially it's coming from the SVC-RA junction if the central line's in the right place. In normals, the central venous sat is moderately higher than the mixed venous oxygen saturation, which we used to get from PA catheters. In septic patients, that's a little less reliable. You tend to have a little less oxygen extraction in the brain, so central venous sat could be higher than the mixed venous sat. In any case, that's relatively low. So the whole picture together is, as you said, relatively fluid resuscitated, with poor LV function, some indication of poor oxygen delivery, and some indication of global hypoperfusion, I would say. And you would like to do something to increase forward flow. I think dobutamine is what you said. I think that would be okay. You have to be ready for the tachycardia and be able to respond to that. I think she's likely to get more rapid. That's the only thing, and we don't know what's going to happen with her actual cardiac output when she gets more rapid. So it's a reasonable option.
She might also get hypo.
She might get more hypotensive with dobutamine because of the beta-2 agonism. In general, patients with truly reduced cardiac function, unless you put them into an arrhythmia, when you use dobutamine, usually their blood pressure goes up. It doesn't go down, but that's not always, you know, you never know. So yes, it's something to think about. Okay, other options other than dobutamine? So we could use milrinone, right? So yeah, so again, it might drop her and probably would drop her blood pressure. Depends again on its overall effect on her cardiac output. There's a less likelihood that she would go into AFib. If you were going to use milrinone, do you know what sort of dosage you would use? Anybody?
0.125 microsecond. 0.2 microsecond. is like lower.
That's a low dose. Yeah, so that's okay. You know.
Not peeing.
Yeah, she's not peeing, so that's a low dose. That's okay. You know, we used to say 0.375 to 0.5 for patients with normal renal function. I know in the cardiothoracic unit they use very low doses of milrinone
If you're
at
not
times.
peeing, yeah.
So, yeah, it's something to be careful about. So if you're going to use it, it would be at a lower adjusted dose, probably. I think those are all reasonable things. You could say DIG. I don't want to think DIG here. It's not a drug that makes me happy, but unless you're going to probably need to use amiodarone next thing you know. So, digoxin probably wouldn't be the greatest drug. So, yeah, you could try either of those. Neither may work. You may just have to deal with this situation. And, you know, the lady may end up needing to get dialyzed. Would you give her blood? To improve her oxygen delivery? Probably not. Even in the olden days of giving blood to improve oxygen delivery, people used to agree that a hemoglobin of 11 was as high as you would transfuse the patient to. So in this day and age, in all comers in the ICU who are truly critically ill, who are not massively exsanguinating, we use a hemoglobin trigger of 7. Patients with acute coronary syndromes, we will should be using a hemoglobin trigger of 8. That does not mean all patients with a history of coronary disease should be transfused at a trigger of 8. It means patients with true acute coronary syndromes. Anyhow. Okay. That's case 1. Case 2, 46-year-old male, no past medical history. Admitted to the SICU from the OR, intubated in septic shock after a lap chole with common bile duct injury, converted to an open procedure. Now, we don't see this anymore either, so I got to drop this case. At the surgeon's insistence, the PA catheter is placed on arrival to the unit. Up until
I get that every so often. Very random. Yeah, sure.
2 years.
Very often, very rarely, I wanted to say, but it can happen. Someone says, yeah, you need a PA catheter, yeah.
Initial numbers on norepinephrine of 0.2 mics per kilo per minute, temperature of 99, heart rate 124, blood pressure 92/52, breathing at 26, CVP of 10. PA pressures are 36/18, a wedge pressure is 14, a cardiac index is 3.4, the SVR is 630, the mixed venous oxygen saturation is 78%, blood gas is 7.32, 36/160 with a lactate of 3.8 on 40%. Patient's intubated and sedated with minimal urine output, has a white count of 32, a hemoglobin of 8. Surgeon wants you to achieve a higher MAP with norepinephrine and give him 2 units of blood and start dobutamine to improve oxygen delivery. I guess he read the early goal-directed therapy articles, the initial one. So what do you think about that? So, yeah.
Systemic vascular resistance is low. That's the reason why he's having a low blood pressure, causing low oxygen delivery and high lactate.
Okay.
That's the acidemia. But he's, and that's the reason, and also septic shock causing low oxygen extraction. That's why the mixed venous is not terribly low.
Okay, yeah. Yeah, so the SVR, I always think we fixate too much on it in general. It is a calculated number. You know somebody's blood pressure and you know somebody's cardiac output or cardiac index, you know what their SVR is. So yes, it does sort of give you a feeling for what sort of shock state the patient's in, but you know, I don't usually look at specifically trying to tweak the SVR. I might be trying to raise the blood pressure.
You gotta tighten this patient up.
Yeah, I know. Unfortunately, you can't get rid of that though. So in the cardiothoracic ICUs, you will see them fixated on the SVR.
Make them tighter.
So anyhow, But you're right. This is showing you a relatively fluid resuscitated, most likely, distributive shock state with some indication of hypoperfusion, given the minimal urine output and the lactate. Question is there a defect in oxygen delivery that you can fix? Do you guys think there is a defect in oxygen delivery that you can fix here? Okay. Okay. Hemoglobin is okay, yeah. So, right, unless this patient is bleeding, the recommendation would be not to transfuse this patient. We know there's nothing to be done with dobutamine here. The cardiac function is fine. And we have good evidence that patients who don't have pre-existing hypertension do not benefit from being pressed to a higher mean arterial pressure than our usual. So this is one situation where I think you can point to the evidence and sort of be insistent with the surgeon. Yes, he made you put the PA catheter in, but now we got the numbers, which is what we expected to get, which is what we used to get 90% of the time when we put a PA catheter in, and we're going to do nothing new. This patient's sick. We're supporting him appropriately. Yeah. Any of those other interventions, I think, particularly using dobutamine or giving blood, are more likely to do harm than good. If you increase the MAP a little bit because you had to compromise with the surgeon and he wants a MAP of 75 to 80, it's probably not going to hurt. But I try not to do anything that I think is shown to be harmful. Any other thoughts? Yeah. I might make, yeah,
well, how much is the actual, that's mics per kilo per minute at 0.2 mics. It's not a very, if you calculate it out, it's a pretty low dose of levothyroxine.
You can go to 1.
The Dr. Eisen answer will be that there's no limit, right? You can go to whatever you need in order to achieve what you want. If the surgeons start to freak out, when you're at a 0.4, the cardiothoracic surgeons really go crazy. 1 is insane, but even it's not.
We've had patients on
they get 150
mics per minute of norepinephrine that have survived.
Survived, yeah.
It sort of depends on your situation. Somebody who I know is dying, who's already very, very tachycardic, making a lactate, I'd say they're at 1 mic per kilo per minute of norepinephrine, no further norepinephrine.
So, that VAST-2 trial, the VAST trial would say that is probably,
sure,
it's just the battery.
Yes, the battery.
The VAST trial would say that it probably is okay to add some vaso. This is that moderate to low dose.
Okay.
So, yeah, that would be backed up by the trial.
So what's the response? You don't want to give dopamine in?
I wouldn't do
dobutamine.
I wouldn't give dobutamine or transfuse the patients. I would tell the surgeon if the hemoglobin's going down further, we will give a unit of blood. Dobutamine is likely to do harm here and put him into some sort of arrhythmia. We can get the blood pressure slightly higher.
So you can press this patient.
He's already on a little bit of pressure, and I
want to compromise
on a little bit more.
A little more blood pressure.
Right now, his MAP is exactly 65. So, all right, we can give you a 70, 75. It's probably not going to make a difference. Might make the surgeon more comfortable. Case 3, 58-year-old man, 7-day status post heart transplant, brought back to the CTICU after developing septic shock and respiratory failure, MRSA in the blood. Not good. TTE shows good systolic function of the transplanted heart. He's febrile. He's relatively tachycardic, as these patients tend to be. And he's on norepinephrine at just below the freak-out dose, 0.3 mics per kilo per minute. The CT surgeon is requesting that you switch norepinephrine to epinephrine. What is your response?
We'll be back to the blood pressure.
I think most of us wouldn't choose norepinephrine as our first pressor, but it's
You mean epinephrine?
Epinephrine as our first pressor here. Really, there's not good data one way or the other on it, and this is a unit where you'll see a lot of epinephrine used, and surgeons with particular preferences. And so this is a place where I don't really have any data to back up my objection to epinephrine. So
I use epinephrine a lot.
if they want us to use epinephrine instead of norepinephrine, I would usually use it, honestly. Issues with epinephrine, sometimes the lactate can go up and confuse you as to what's going on. You know, make you think that potentially the patient has an ischemic valve. That's most of the thing I would say about epinephrine. It tends to bring blood pressure up. Yes, it has effects on beta 2, but overall it tends to bring blood pressure up.
Usually very rarely would I switch norepinephrine to epinephrine, right? But what I would do is I would add a low, because it's the number that's freaking them out, right? That 0.3 is just a freak out number for them, right? Because 0.4, the patient explodes, right? So 0.3 is a freak out number for them. So I would add like a very low dose of epinephrine, and probably it'll bring down that number and then make them more comfortable. And then you can decide which one you want to wean off first as the patient gets better. That's usually what I do.
Yeah.
But I like using it as a second-line pressor. I don't have a problem, and you know the SDCM recommends using it as a second-line pressor before vasopressin or phenylephrine. It's just norepi then epinephrine is their recommendation. So in a case like this, I wouldn't go crazy. I would just add a little bit of low-dose epi and bring that number down. Then they'll say the patient's getting better, right? You're doing the same thing. You're just replacing one catecholamine with another catecholamine. There's no science behind it. And it's okay that there's no science behind it.
Okay. Case 4, called to the ED, 48-year-old female, high fevers, dysuria, and flank pain. Urine microbes packed with white cells. After getting antibiotics and 8 liters of saline in the ED, she started on dopamine for a persistent blood pressure of 80/40. With dopamine at 10 mics per kilo per minute, she's become more tachycardic to 1/45, but her blood pressure is actually a little lower. She's in moderate distress. She has CVA tenderness and a loud systolic murmur. Her renal sono shows moderate to severe left-sided hydronephrosis. Urology says, yeah, we'll do a perc nephrostomy, or actually, realistically, they'd have IR do it probably, but they want her stabilized first, which is reasonable. You don't want her going to the IR suite with that blood pressure. So what would you do here? What would Shiloh do here?
I know what I would do.
What would Shiloh do?
Yeah.
He'd freak out. He would yell at everybody in the ED. No.
That's not even slightly possible.
No way. No way.
I know exactly what I would do.
Any thoughts? You're like the console fellow. You're pushing this machine around. You got your bag. Yeah. Okay. You thinking Neo? Okay. Okay. Why would you think Neo? Maybe?
Because she got so tachycardic.
Yeah, okay.
Probably was with her belief actually, but she was that really not tachycardic, and he thought it was very contributing to her blood pressure.
Okay. Okay. So why would that tachycardia contribute to your blood pressure? Because usually, if you're 48, that's about, it's not quite maximal heart rate. I can get up to like 150, something like that. My blood pressure. Yeah. What's that?
That's it?
Yeah. Sorry. What's that? Okay. Okay. That's possible. Right. So we talked about, like, for instance, patients, particularly like patients with mitral stenosis. That used to be a classic patient who needs more time. But other patients, that could be an issue as well. Anything specific about her? We did a physical exam. We heard a murmur. You never hear a murmur. This is like the first time you've heard a murmur in like a while. Anything else you might want to do? You remember? Okay, I see the people's risk. Yeah. So you want to do an echo, right? Right. Exactly. So yeah. So what sort of patient gets more hypotensive as they get chronotropy and inotropy? Sort of have a paradoxical response to chronotropes and inotropes. That you might find on that. MR. With that, MR. Mitral stenosis, yes, in terms of chronotropy. Not sure so much about MR. I mean, if you...
MR, you just have, the EF stays the same,
Yeah.
and it doesn't matter, right?
Yeah. Aortic stenosis. So aortic stenosis is a tough situation that I've never really been able to figure out how to fix. It's just this fixed outflow obstruction. I can't really win with it. We know we don't like to systemically vasodilate those patients. If she got more tachycardic, inotropy might help, might not help. Chronotropy, once it gets too fast, probably wouldn't help if you have severe aortic stenosis. Anyone else? Outflow tract obstruction.
One we saw the other day, right? It's the same patient. That's what
30 years younger.
right?
30 years younger. But these patients tend to be young. Well, not always,
Yeah.
but a lot
A
of...
real Holcomb physiology is
Yeah.
young, right? It's like secondary hypertension that can give you like an LV outflow tract obstruction just from concentric, just muscle growth, right? But that's what's gonna have you no chamber size.
Yeah.
So, but that's what was happening with that person the other day, right?
Yeah, we have Our Lady upstairs, right? Although she's kind of a mixed, weird state.
Oh, we put someone in the CCU.
Right. So this would be a person, I think, yes, your reaction was right that tachycardia is doing something bad for her. She's somebody has a specific problem, probably. So I kind of think of this as like the PFO of the pressor. A couple times a year, think about it. Try the right intervention and everything goes the wrong way. It's like when you add PEEP and somebody gets more hypoxic, you're adding pressors and the patient's getting more hypotensive.
But you did an echo first, so everything
So
was
you would have
okay,
done an echo
right?
before any of this, right? So
Yeah,
and
before
actually,
you even listened
yeah,
for the murmur.
you would have. So, okay. Cool. So yeah, so neosynephrine would be a good alternate, vasopressin, neosynephrine. It's hard to beta block this person at this point. Can't really do that, but you can do things to bring their heart rate down and increase filling time. Okay, case 5. I don't remember this. 75-year-old male, coronary disease, heart failure, COPD, admitted to the CTICU post-CABG, on milrinone 0.3 mics per kilo per minute, temperature is 96, heart rate 60, paced at blood pressure of 96/60, respiratory rate of 18, CVP of 20, PA pressures are 58 and over 28, cardiac index is 1.4, SVR is 1200, central venous oxygen saturation is 54%. Blood gas 736, 4295, lactate is 2.1. Hemoglobin is 9.3, urine is oliguric. You increase the milrinone. This is like classic 10 o'clock at night. Dr. Shiloh's on in the CTICU. He's increased the milrinone. He's like, I'm not going to have to make the call. Tell me I'm not going to have to make the call. Increase the milrinone.
Make the call on what?
But subsequent, no, call to the cardiac surgeon.
Oh.
Subsequent cardiac index is now only 1.5. So it's not really helped, and the central venous stat is down actually. Heart rate remains 60, paced, blood pressure is a little lower now, 82 over 48. Any thoughts on what to do? Poor Colin.
middle of the night?
This is
It's
10:45.
11:59.
It's 11:59. Before you call the cardiac surgeon. What did you do?
He's paced, that's the
Okay.
problem.
Okay.
Ideally, the first thing you would want to do is call whoever to reset the thing so it's a pace higher and to get it better.
Yeah, no, it's yeah. You can.
These patients all
You mean
come out with
it's their own pacemaker? He means.
with external
Yeah.
pacing.
Oh, it's
Yeah,
external pace?
Yeah, I don't. Yeah, I mean.
They all come out.
Yeah, they come. Yeah. So the patient. What he means. Yeah, you're right.
I
Your
should
patient.
say-
You can adjust the rate yourself. Yeah.
Yeah.
And see if that helps with the pressure.
Okay. That's the only point here. You know, normally in a shock state, whether it was cardiogenic, septic, whatever it is, obstructive, you would get tachycardic. Everybody gets tachycardic. So if you've done something like done a big cardiac surgery and taken away their intrinsic heart rate, which these patients are frequently asystolic underlying, and you're pacing them, you need to pace them physiologically. So heart rate to 80, 85, usually what the cardiac surgeons ask for, and it helps. It's easy to do. So something to think about. Sometimes we think about in other patients who are paced, septic shock patients who are paced. And
Sometimes we do call EP, you know, and they increase the patient's
they've
heart
put
rate.
the magnet on them,
The
their heart rate
magnet,
goes up to 80 anyway, so that's
See,
good.
again, it has to be delivered to the back of them.
Huh?
If it means they don't have to come in, if you can find a magnet. So
Very hard to find.
They don't have it in the
I think they do in the OR.
If you have to think about where to find them, that means it's hard to find the magnet.
The OR. All right, 443. That's all I got. I'm finding ultrasound.
So there's a big case.
Yeah.
It's one of these GU cases. We took every single part of his GU system out of his body